Good morning. This is VRikken. I'm a student at Aspen University, enrolled in the Informatics and Healthcare program. And today I'm presenting my PowerPoint signature assignment for Professor Orr. Today's date is May 8th, 2019. Today's discussion in PowerPoint presentation is algorithms and electronic health alerts. I'm going to discuss the use of a new informatic technology process by applying algorithms and guiding evidence-based practice to patients who require central line use. We're going to review the relationship of electronic health record surveillance for documented comorbidities and international classification of disease codes known as ICD codes as a tool for identification of patients who are at potential risk for central line associated bloodstream infections known as CLEBCs. This initiative would establish patients who are at risk. It will provide high alert risk warnings into the patient's electronic health record for clinicians and healthcare providers. We're going to discuss how CLEBCs are related to my professional practice, the application of reviewed scholarly research to current nursing practice, while providing a summary derived from the research. I'm going to highlight the ethical and legal issues related to this initiative and now how it will affect providers. We're going to justify the plans for this change, define job roles of the employees who need to be involved, and provide financial mapping for the change. We will reveal public policies that dictate and influence factors on healthcare. Algorithm and Electronic Health Alert Initiative. Central line complications are a major contributor to the increasing costs, morbidity, and mortality rates of American patients. Professional practice relationship is providing vascular access to patients, including the placement of peripherally inserted central lines, known as PICC lines. As well as doing that, I educate staff on CLEBCs and prevention, monitor alt-tunneled and non-tunneled central lines, review electronic health records to investigate the eligibility for central line placement, while offering alternative methods for safe venous access care. I monitor patients with central lines for line necessity, advise the removal of central lines daily if peripheral access can be established, while promoting proper central line care and maintenance to employees, patients, and families involving the CLEBC bundle. What's the definition of a central line? It's an intravascular catheter that terminates at or close to the heart in one of the great vessels which is used for infusions, the withdrawal of blood samples, or hemodynamic monitoring. There are two categories, tunneled and non-tunneled. Permanent dialysis catheters, Grosham's, Hickman's, Broviac's, and implantable ports are all tunneled catheters. Non-tunneled catheters consist of PICC lines, trialysis catheters, and subclavian catheters. Who are candidates for central line placement? Patients with therapies with extreme variation osmolality greater than 900, infusion of cytotoxic vesicants as in chemotherapy, non-cytotoxic vesicants as in hemodynamic medications as in Levophed, no alternative access, nutritional therapy as in total parental nutrition or TPN, long-term antibiotic treatment greater than 2 weeks, or hemodynamic monitoring. Let's define a CLEBC. This occurs when bacteria or other germs enter a central line and then into the bloodstream. It's related to the presence of intravascular devices, as I had mentioned 2 slides previously. It's defined as a laboratory-confirmed bloodstream infection, not related to a current infection from any other site. There is an infection window period, which consists of 7 days. That includes the date of the collection of the first blood sampling that identifies an organism in the blood, and 3 days after, and 3-day calendar days before. It's measured as the number of events per 1,000 patient days. CLEBCs are a never-should-happen event. The Institute of Medicine's report establishes that CLEBCs are a priority area for national attention. My current organization of employment has had 17 CLEBC-associated deaths this year. 5 million patients receive central line catheters each year in the United States. 1.7 million catheter-related infections occur each year from all types of organisms, which means 99,000 deaths occur each year as a contributing factor to hospital-acquired infections. Why CLEBCs are important to healthcare. CLEBC deaths exceed the risk of dying from AIDS, breast cancer, and motor vehicle accidents collectively. 250,000 confirmed cases of CLEBC each year prolong hospital stays, increase the risk of morbidity and mortality. Of all hospital-acquired infections, CLEBCs are the most costly, approximately $46,000 per case. The consequences of CLEBCs. CLEBC rates are a key quality metric for comparing hospital quality and safety, non-payment by centers of Medicare and Medicaid services, and insurances for hospital-acquired infections. The inclusion of all hospital-acquired infection rates is part of the value-based purchasing program of the Affordable Care Act. Federal reporting incentives has had a significant role in the reduction of CLEBCs over the last decade. Potential penalties, damages to organizational reputations, and auditing from the Joint Commission of Accreditation of Healthcare Organizations, known as JCAHO, happens when we have CLEBCs. Algorithms and electronic health record research. A symposium consisting of international healthcare epidemiology programs from 11 leading institutions across the country, with qualifications that consist of authorship and leadership in their field of practice, occurred. The discussion of the potential for using electronic health records, of which contains a wealth of information, and this is just all becoming discovered now. Epidemiologists, infection preventionists, state and government agencies have the ability to look at vast amounts of data and make interpretations and predictions. The National Healthcare Surveillance Network and Centers for Disease Control and Prevention believe that the risk adjustment for CLEBC can be improved by including patient-specific comorbid conditions into the patient's electronic health record. The discussion. ICD codes are used by institutions for billing and coding. That is required by CMS. Comorbid conditions potentially cause patients to be at a greater risk for CLEBC. Comorbid conditions found through ICD codes can easily be obtained for hospital-acquired risk adjustments. The CDC strongly suggests using ICD-based comorbid risk adjustments in the future for prediction, validity, and the reduction of CLEBCs while using a web-based multi-tiered surveillance system. Key contributing risk predictors. Multiple attempts of insertions, insertion site selection, rewiring of catheters, line days, emergent or non-emergent insertions, and readmissions. Another key contributing risk predictors are comorbidities, which consist of diabetes, hypertension, heart disease, coagulopathy, drug abuse, paralysis, HIV, AIDS, liver disease, malnutrition, renal disease, obesity, and lymphoma. My findings are as such. Retrieval of patient data from hospital databanks for prediction is based on the knowledge discovery rules implemented in the CLEBC decision algorithms, and then implementing best practice advisories within the electronic health record. Change in providers' behaviors and attitudes to the use of central lines needs to occur. Using existing electronic health record databases with patient-level variables can perform exceptional surveillance of prediction for CLEBC. Some of these risk factors that are intrinsic are age, gender, and underlying disease and comorbidities. Primary diagnosis codes for first readmissions are consistent with CLEBC prediction diagnoses. Longitudinal visits across different facilities provided demographic information and clinical data for risk adjustments, significantly associated by a readmission to an acute care facility. Summary of research material. Surveillance with an electronic system is feasible and highly effective. Surveillance trail would remain with the patient from past, current, and future patient admissions. A full scope assessment needs to happen when ordering central lines, establishing risk versus benefit, or if patient is requiring hemodialysis. Knowledge is power. implementation of proper care to high-risk patients, establishing accountability and communication between professionals. Alert banners for clinicians in the electronic health record will remind them to do the right thing, providing no shortcuts in prevention of CLEPSIs. Examples currently in place for high alert banners are for high fall risk patients or if interpreters are needed. Hospitals, patients, clinicians would benefit from data retrieval and implementation. If CDC and CMS adopted risk adjustments for CLEPSI reporting, all would reap the benefits of doing so. People and strategies for this development plan. Information technology engineers would be advised by informatic nurse specialists of the plans. Collaborative meetings would occur amongst administration, infectious disease, physician representatives, infection control, intensive care nursing director, vascular access nursing director, and nurse informatics specialists. Mandatory employee educational modules would require sign-off for completion. Communication with use of flyers of go-live dates to all the nursing units with discussions at the huddle board shift change report. EPIC educators would inform the physician groups and newly hired employees of the new information technology concept. Administration would inform current physicians of the new organizational mindset and tools to assist in organizational efforts to eliminate CLEPSIs. Safety nurse champions for each nursing unit would act as a resource for troubleshooting issues. Most effective strategy for CLEPSI prevention is to reduce and avoid central line placement. Ethical and legal considerations. Ethically, it is a nurse's responsibility to help patients heal without complication. This would have a direct reflection on hospital readmissions. The goal is to prevent rehospitalizations within 30 days of discharge, consideration of disclosure of patients' private information and the employee's need to know, regulatory monitoring of the employee's use and management of their computer activities, to be knowledgeable of the security and policies of the interoperable systems with which the exchange of data is occurring within, implementing universal standardization of the algorithms used for detecting ICD codes for risk adjustments, considerations for the operational policies and handling procedures of implementing data access and exchange, and then considerations for the liability of an organizational security breach from a second-hand party with whom data is shared, compromised, or stolen. Signs of success. A trial run for prediction accuracy, successful implementation of this algorithm within the system, demonstrated by high alert visibility on a patient's chart who is at risk. Does the program exude robustness, efficiency while eliminating time? Collaboration and adoption of processes within the organization? Patients' care team members daily acknowledge with sign-off high alerts in the chart. Successful completion of staff members' educational requirements. Important conversations being had for the patient's need for central line access. Prompt removal when no longer necessary. Staff participation with survey for important feedback on successes, problems, and barriers. Financial mapping. Costs are related to the size and functions of algorithms. Government contributing influences are present with funding and distributions. The return revenue is rewarded as less CLEPSIs occur with practice change. Limited funding and access resources are a challenge and common in information technology. As information technology continues to grow, the cost factor for software is decreasing proportionately. Public policies and technological advancements. It would be ideal if future potential algorithms could be established through the provisions made creating CLEPSI algorithms as a template. Regulatory bodies of the government initiate policies for which informatics is practiced. Complying within these policies that reflect CMS and JCO ensure compliance in federal regulatory standards. Value-based bundled payment models for care improvement strive for higher quality and more care coordination at a lower cost to Medicare. In conclusion, Implementation of algorithms with the new multi-tiered data surveillance system for CLEBC prediction from data collection sources will efficiently and accurately provide CLEBC risk alerts. Surveillance is automatically processed upon patients' initial encounters to hospital settings. It will help medical physicians, organizational decision makers to review and approve policies to support evidence-based practice with the use of central lines for their patients. It will provide alerts for high-risk patients that are visible upon opening the electronic health record. It helps to prevent loss of lives, reducing treatment costs, and keeping hospitals safe from tragic sentinel events. This is the end of my PowerPoint presentation. I very much welcome you and thank you for any feedback that you offer me. And at this time, I would like to extend my warmest well wishes as you continue your educational endeavors through Aspen University, and I wish you much success. Thank you.